For my ethical dilemma, I chose quality versus quantity of life. Trying to define quality versus quantity of life itself is pretty hard. Right off the bat, the quote by Maya Angelou came to my mind. So the one that says life is not worth measured by the number of breaths we take, but the moments that take our breath away. I did some research, and according to a very renowned doctor, about the age of 75 is when we hit a major decline in mental acuity, and then the physical decline follows. So while you might see commercials and TV shows and movies with 60, 70, and 80-year-olds out there doing thrill-seeking, adventurous things, that's not the majority. That's a very small number. The majority are typically immobile, have sedentary lifestyles, may be widowed, have many comorbidities, and are often taken care of by someone else or in a skilled nursing facility. So getting into more of the ethical dilemma that's related to quality and quantity of life really is euthanasia. And the more I read, I understood and realized that all of these terms are often used synonymously when they are not actually synonymous. There are actually 4 types of euthanasia. The first one being passive. So passive is when you stop life-sustaining measures like giving food and giving oxygen. You may still be giving morphine or keeping them on a heart medication, but you're pretty much removing everything else to sustain their life. There is indirect, and so that's like when someone's very sick, they're septic, they have COVID, they've been intubated for 4 weeks, and they're 80 years old. They have a history of heart disease, stroke, osteoarthritis, and 7 other things, and you give them a dosage of morphine that may not kill them, but it may very easily help speed up the process of them passing because it's going to help their organs shut down because they're unable to process it. Active euthanasia is one of the most popular. That's been around since like Greek and Roman times. That's what Hitler did with the Jews in concentration camps. That's what we do with animals at the vet clinics. And then there's physician-assisted suicide, sometimes also referred as medical aid in dying, but often they do not like it when they're used interchangeably. But physician-assisted suicide would be like Dr. Jack Kevorkian, which is Dr. Death, and he helped people find the means and the mechanisms to kill themselves in a peaceful way at home so they could end their suffering. One of the major factors right now that is correlating with euthanasias or physician-assisted suicides is the U.S. population and the dramatic increase in the aging population. So by 2034, there's going to be more boomers, which are age 65 and up, than there are kids, and kids being considered 18 and under. By the year 2060, it's expected that 1 in 4 Americans will be at least 65, and the number of 85 or older adults will be triple what it is today. So as far as our culture goes, we put a very high value on life, as we should, but we also have a fear of death. We ignore death. We don't like it. We don't do a lot of the ritualistic things that other cultures may do with the dead bodies. We don't like to see it. We want it taken away, clean it up, dress it nice, and have a lovely viewing, pretend like you never saw anything bad, don't talk about it, etc. We have what I like to call a death-denying culture. So what I mean by we're death-denying, we like to prolong measures, life-sustaining measures, for people that will not have or may not have a quality of life. So, for example, all the COVID patients that we've seen, or cancer patients in clinicals, things like that, that are intubated, they're sedated, they have pressure ulcers, all these comorbidities, they've been intubated for 4 weeks, and their chances of surviving off the ventilator are very slim. That's what I mean by we take measures as a Western society to prolong life, even when the quality of life is going to be very poor if they even make it out. To bring history class into this, I looked up some things on the U.S. Constitution, And we all know the saying of having the right to life, liberty, and the pursuit of happiness. And so my question is, if that's what is stated and we have the right to life, why don't we have the right to death? Liberty is considered a state of being free, but are we really free if we aren't able to make all of our decisions autonomously? And happiness. If we're in control of our happiness, what if quality of life is what we would prefer over quantity of life? So instead of living and counting the years that go by, you appreciate the quality that you had up until the age 76, when you then decided you wanted to end your life because you had a terminal illness. So it's not as easy as just saying, hey, I don't want to be alive anymore. To be considered for physician-assisted suicide or medical aid in dying, you have to be an adult resident of a state that does practice this. You have to be capable of making your own decisions and have no altered mental status. You have to be diagnosed with a terminal illness that they expect that is going to lead to imminent death within 6 months. And you have to be capable of self-administering the medications without any assistance. There are 9 states plus Washington, D.C. that now have variations of passive euthanasia or physician-assisted / medical aid in dying. Oregon was the very first one to go through with an act in 1997, and the most recent is New Mexico, which was just last year. There are also 29 other countries that partake in some form of passive euthanasia or physician-assisted suicide as well. Reasons that people are usually against it include thinking that the right to aid people in this or having the ability and capability and permissions to do this is going to be abused by doctors and relatives, and that it can increase crimes, and those crimes would then be masked by this. Pressure of an individual to pursue going through with death because they feel like they're having financial troubles, they are a financial burden, or they feel like a burden to their family. The people that are against it also think there's going to be a halt in scientific research, because if we don't let all of these terminal illnesses progress into the late stages, then how are we going to find a cure or a treatment for them? And lastly, and probably one of the largest one of all of those, is religious and spirituality. So, like the quote, life is a gift from God and only He can give or take it away. It's very widely believed by Christians that you cannot take your own life. I am personally for the idea of dignity with dying or physician-assisted suicide, whatever you would like to call it. A couple of the ethical principles that came to mind for me were informed consent, because if you are going to be a nurse that is dealing with this, or you work in a state that does this, you have to know the rules, the laws, the protocols that go with it. The patient needs to be fully aware of the decision that they are making and comfortable to say yes or no after they've gotten all of the information. The next thing is, like I said, dying with dignity. You want to respect that individual and the life, liberty, and the pursuit of happiness. If we have the right to life, why don't we have the right to death? We should have an autonomous choice in this, given that we meet the criteria stated in those before mentioned slides. Veracity and advocacy is creating a trusting relationship between yourself and the patient, comforting them, trying to alleviate any pain and stress, anxiety that they may have, and just offering support without bias. So whether they actually decide they want to go through with it or not, you are there to support them either way. As far as justice and non-maleficence, the best thing you can do as a nurse or someone in the healthcare field is just being knowledgeable about patient rights and the pertinent protocol, laws, and any changes and amendments that may be made to them. So I looked up the ANA's position statement on physician-assisted suicide, which I think they actually word differently, but it read, the delivery of high-quality, compassionate, holistic, and patient-centered care, including end-of-life care, is central for nursing practice. Hallmarks of end-of-life care include respect for patient self-determination, non-judgmental support for patients' end-of-life preferences and values, and prevention and alleviation of suffering. So as long as you are abiding by all of the rules and protocol within the states that can conduct these procedures, the ANA gives nurses full support to assist with this and advocate for it. The other quote that I snagged from their website was, nurses recognize that death is part of the natural continuum of life and respect that end-of-life decision-making is multifactorial and deeply personal. So while some may think they want to do it, they may end up changing their mind, and that's completely okay, and that's what we're there for as nurses. So again, I already told you that I am for it. With that being said, I do think there are some things that have to be taken into account. I do for sure think that palliative care or hospice care should be tried first after you've tried pain management and other alternative therapies. If chemo's not working or radiation's not working, things are making them sick, they're getting worse, and then palliative care and hospice are also not doing their job, then I think it's time to allow them to make that decision or think about it at least. They at least need to be informed that it is an option for them. With that being said, if they go through with it, you need to abide by all laws. You need to provide informed consent on the prognosis of their diagnosis, the risks and benefits of doing it, and allow them to ask any questions that they might have. You have to give them unbiased support, which I already mentioned. You don't want to sway their opinion one way or the other. And I did mention that we are having an aging population approaching in coming years. So especially for all of us that are just going into nursing, we're going to see a very large, dramatic increase in sick patients with comorbidities. We're going to have more old people than we've ever had in the history of us being alive, at least. And that's going to increase the need for nurses, supplies, and medicines, and in turn is going to put us at risk for shortages of staff, supplies, and medicines, just like COVID has. So healthcare disparities will result from the overpopulation of the sick boomers, just like the healthcare disparities that came out with COVID. So if they're willing to choose death, I think that as long as it's done rightfully so within the guidelines and stipulations, then, that's a dignified and a brave thing to do that then allows a possible ventilator or hospital bed that could save another life. Whether it's somebody that's younger, somebody that's healthier, or somebody that has a better chance to have a more quality of life, I think it's a really brave and selfless thing to do. In conclusion, just to wrap things up, this ethical dilemma is not going to go anywhere anytime soon. We'll probably deal with this for the rest of our lives. While I would imagine more states might jump on the bandwagon, I don't think it's ever going to be completely accepted worldwide because of things like religion and spirituality. It is available in the United States and those 9 other countries. And it's just really important to advocate for your patients. If you do really feel strongly about this, something that you could do is work in a state that does perform these procedures. And if you're against it, that's totally acceptable as well, because we are all entitled to our own opinion. And if you aren't for it, then it would probably be best to think about staying in a state that does not provide these practices so that you don't submit yourself to something you don't stand for. And here is a list of all the references I used for my paper and presentation. Thank you.